Let's start off this lecture with a couple of definitions. The first being what really constitutes hypertension. And hypertension is going to be defined by the World Health Organization as any combination of blood pressures greater than 140 systolic over greater than 90 diastolic. So when you ask somebody what normal blood pressure is and they say it's 120 over 80, in fact, that is the high limit of normal, where any value between 120 over 80 and 140 over 90 is actually considered prehypertension, and that's what we have right here. So that's prehypertension. High blood pressure, therefore, is going to be subdivided into a couple of different areas. You're going to notice that there's a stage 1 and a stage 2 hypertension, and you'll see some values that are being supplied here. We're not really going to concentrate too much on stage 1 versus stage 2. What we might indicate as being a little bit more important is when we have something which is called the hypertensive crisis. And a hypertensive crisis is greater than 180 or greater than 110 diastolic. This is typically going to indicate an emergency referral, and these individuals have to go to a primary healthcare provider. One of the reasons why we care about talking about hypertension is recall that anytime an individual has an elevated and persistent hypertensive state, the individual is going to compensate by having left ventricular hypertrophy, and we know that that is going to be an increase in their risk of developing cardiac failure. As a result, as time marches on, the individual's heart actually starts to become a little bit larger. What we have in this particular slide is something that is called essential to primary hypertension. And this is where we're going to pay a little bit more attention. When we look at hypertension, we either know the cause or we don't know the cause. And in many cases, we really don't know the cause of hypertension. And in those cases, we call that primary or essential hypertension. It's something that just occurs by itself. And this tends to increase as an individual ages. And there's an unclear etiology. It is thought that it is linked with age, the genetics of an individual, poor diet, lack of exercise, whether or not you are sedentary or not, your BMI as well. If in a case narrative we don't mention any other organ system, I want you folks to think about essential or primary hypertension. The moment we start to name other organs as being the cause of hypertension, then we're looking at a secondary hypertension. And you're going to notice that there are some commonalities. First of which is that we tend to include renal diseases. And so you're going to notice in this slide, in secondary hypertension, we have 4 different renal causes. And allow me to briefly describe each one of them. In our last unit of study in this course, we're going to go in much greater detail on kidney disease. Be that as it may, let's give a quick 30-second explanation of each one of these. A polycystic kidney disease is one in which an individual's kidneys will develop these expansile fluid-filled cysts. And these cysts aren't really functional kidney tissue. And so I'm just kind of packaging these little cysts inside of a kidney, just like that. There's the ureter there, and there's the ureter there. The thing is if we have cysts in the kidney, that's not really kidney tissue, and as a result, we're destroying kidney tissue. As a result of that, the individual is incapable of actually producing urine, and so you're going to see that the individual's urine output decreases. Well, if urine output decreases but intake of fluids remain the same, the individual's blood volume is going to increase, and that's what I'm showing with the letters B and V, with this arrow up. If blood volume increases, well, the individual's blood pressure is going to increase as well. If I skip down to chronic glomerulonephritis, a very similar situation is occurring. This is going to be due to frequent and recurrent infections at the level of the glomerulus and the nephron itself, and as a result, the individual is going to lay down scar tissue in the kidney. And much like how we talked about in polycystic kidney, if we're replacing the kidney with non-functional tissue, well, the same things are going to apply. The individual is not going to be able to produce adequate amounts of urine. As a result, blood volume increases and blood pressure also increases. In these next 2 examples, we'll have a slightly different instance. A renin-secreting tumor is exactly that. This is a tumor that originates from the kidney, which increases circulating levels of renin. Well, when you increase renin, that is going to cause the activation of angiotensin 1. That's what I'm showing with these letters here, AT1. And you know that angiotensin 1 is going to be converted into angiotensin 2, and that's what we have right here. And recall that angiotensin 2 causes you to become thirsty. It is also going to cause peripheral vasoconstriction. It is going to increase your heart rate and whatnot. And as a result, the individual's blood pressure increases. In renal artery stenosis, if we look at the renal arteries right here and right here, and we just kind of draw the kidneys, one right here, and we're going to draw one right here as well, and the aorta is right here. I want you to imagine for a moment that the individual has atherosclerosis, specifically of the renal arteries. So what I'm drawing here is going to be an obstruction of the renal arteries. As a result, the amount of pressure being delivered to the kidneys to produce adequate amounts of urine begins to decrease. And much like how we've talked about in systems phys, if you have decreased blood pressure going to the kidneys, the juxtaglomerular apparatus is going to say, well, where the heck's the blood pressure? As a result, it is going to secrete renin, and we have an activation of the renin-angiotensin-aldosterone system. Again, same thing applies. The individual becomes thirsty. They have peripheral vasoconstriction. They will have increased contractility of the heart, and the individual's blood pressure will increase as a consequence. Notice here, we're going to start talking about adrenal diseases. Again, the adrenal glands are perched above the kidneys, and we've heard of many of these particular conditions. In the case of a Cushing's syndrome, the individual is going to have high circulating levels of cortisol, and so that will be important diagnostically. As a result, the individual's blood glucose is also going to increase, and so that's what I'm showing you as the letters B and G right here. Individuals who walk into your office with Cushing's syndrome have that very characteristic round or moon-like face, that truncal obesity, wasting away of the extremities, and purple striae, as well as that increased amount of adiposity on their shoulders, which we call the buffalo hump. Anytime you increase the amount of solute, and in this case blood glucose, what's going to happen is that water is obligated to follow to obey the rules of osmolarity, and as a result, the individual's blood pressure will increase. I'm going to skip over Addison's disease for a moment because that is going to be the one exception to these adrenal diseases. In fact, blood pressure decreases in this case. So if you end up seeing Addison's disease as a potential cause of hypertensive disease, I don't want you to select that one because in fact it causes a decrease in blood pressure. I just wanted to make sure that we mention this because in subsequent units we'll be talking about Addison's disease as an endocrine disease. Conn's disease is going to be called primary hyperaldosteronism, and in this particular case aldosterone is going to increase. And if we refer back to some of our physiology notes, aldosterone is going to be responsible for the sparing of sodium ions. And so if we increase aldosterone levels, we're also going to increase sodium sparing. And much like when we have an increase of solute, much like glucose in Cushing's syndrome, increasing sodium is going to cause you to retain water. So increased sodium results in increases in the retention of water, and as a result, an increase in one's blood pressure. A pheochromocytoma is going to be a tumor in which an individual increases their epinephrine and norepinephrine concentrations. So that's what we have with Ne as well as N. Recall that epinephrine and norepinephrine is going to elevate heart rate. It is going to cause you to have peripheral vasoconstriction. Individuals are going to be jittery. They're going to be anxious. They are going to have a much higher blood pressure as well. And these individuals can sometimes almost have this kind of a paranoid type of personality to them. They're always having that adrenaline rush, which we know isn't a really pleasant experience. We can also look at the pituitary as being a potential cause of hypertensive heart disease. And remember that the anterior pituitary is going to be responsible for the secretion of 6 separate hormones. And you're going to notice that we've listed these guys here. In the case of growth hormone, an individual who has an increase in growth hormone will end up having hypertrophy and hyperplasia of numerous different tissues. And one area where you're going to have hypertrophy is hypertrophy of blood vessels. And what ends up occurring is that, let's say that the normal contour of a blood vessel looks like this. And so that is the thickness of the blood vessel, and the letter L here is going to be a lumen. In individuals who have acromegaly or gigantism, the actual wall thickness of a blood vessel increases such that the caliber of the lumen decreases, and now you have a smaller hole for which blood can pass through. That is going to increase the amount of resistance for blood flow, and as a result, increase blood pressure. You'll notice there are a couple of different instances in which we're talking about the thyroid here, so allow me to elaborate on this. In this particular case, we have increases in TSH. If an individual has an anterior pituitary tumor, which is going to increase TSH, it's also going to increase T3 and T4. Remember, these are thyroid hormones, and individuals who have increases in T3 and T4 are going to have hyperthyroidism. One of the effects of hyperthyroidism is that we're going to have an increase in nerve conduction velocity, we're going to have increase in heart rate, so the individual is going to have this increase in cardiac output, and as a result, their blood pressure is going to rise. Remember how we talked about Cushing's disease? Well, this is one of the primary causes of a Cushingoid pathology. ACTH, which is produced by the anterior pituitary, goes to the adrenal cortex and tells the adrenal cortex to make additional cortisol. And so, meanwhile, while an individual can have an adrenal cortical tumor producing cortisol, they can also have an ACTH producing tumor at the level of the anterior pituitary, which will also increase cortisol. In this particular case, this was a typo. You can put down TRH. Remember that TRH isn't really a pituitary hormone, but rather what it is a hypothalamic hormone. Remember that it's TRH, which is produced by the hypothalamus, which can tell the anterior pituitary to make TSH. TSH then goes to the thyroid to tell the thyroid to make T3, T4. And so any increase of any one of these substances supraphysiologically is going to increase thyroid hormone levels and therefore increase the chances of a hypertensive heart disease. The rest of these require somewhat of a different type of explanation. Individuals who have sleep apnea end up having a compensatory issue in which blood vessels, when they are in a low oxygen environment, will undergo vasoconstriction. So under normal operating conditions, blood vessels, when an individual is breathing normally, are going to have a certain amount of vascular tone. What ends up occurring is that individuals who will have sleep apnea stop breathing at night, and especially pulmonary vessels begin to vasoconstrict in their attempt to shunt blood to other parts of the lungs. As a result, you're going to have this back pressure of blood that is going to increase an individual's blood pressure because you're increasing the total amount of resistance to blood flow. If we look at various drugs that increase our chances of developing high blood pressure, such drugs would be some of your sympathetico-mimetic drugs. So when we say drug-induced, we can say both prescription or illicit drugs. So examples like amphetamine-based drugs will increase an individual's heart rate and as well increases the chances for a hypertensive heart disease. Preeclampsia is going to occur within the context of pregnancy, and in certain cases we don't know why an individual is going to develop very high blood pressure, but in pregnancy it's just been found out that sometimes the placenta will actually produce an anti-angiogenic factor. And what do I mean by that? The placenta is going to make a factor that tells the mom not to build brand new capillaries. And the issue with that is that as an individual becomes pregnant and as they move through their pregnancy, they actually carry more blood volume. And one of the ways that we can accommodate this increase in blood volume is by producing additional capillaries. Well, if the placenta tells mom not to make new capillaries, but we still have this increase in blood volume in order to provide the fetus with good nutritive blood supply, well, we're not going to be able to accommodate that blood volume, and as a result, blood pressure will increase as well, sometimes to dangerous levels, which require us to deliver the baby by way of cesarean section. We've already discussed coarctation of the aorta. Remember that coarctation of the aorta is when a portion of the arch of the aorta has this thickening and a decrease in the luminal diameter. Recall some of the features with coarctation of the aorta is that you're going to have high blood pressure prior to the coarctation, and you will have decreased blood pressure following the coarctation. And so one of the ways that we can assess hypertensive heart disease is by weighing the heart. Many times this is going to occur post-mortem. We can also use Doppler ultrasound to be able to look at blood flow going through the heart and actually get a ballpark figure as to the mass and therefore a potential diagnosis of hypertensive heart disease. Anytime we have a heart that weighs more than 375 grams in men or 350 grams in women, we're looking at a hypertrophic heart. And one of the things that I want you to look at in the next slide is how this hypertrophy that occurs results in cells that are not only larger. So what I'm trying to do here is I am outlining a cell, but also the nuclei, they will also increase in size. And we give this set of nuclei a very characteristic term. We call them boxcar nuclei. These are called boxcar nuclei. The reason why the nuclei get very large is because the nuclei are now active. They are telling the muscle cell to build brand new constituents. And so we are transcribing and translating the message to produce brand new sarcomeres. Again, we see this occurring in the left ventricle when it's systemic hypertension. Look at the thickness of this left ventricle. You'll also notice how the actual chamber of the left ventricle decreases in size. Along with this increased thickness in the chamber size, recall that blood that is being perfused, and here we have a little example right here, it's going to have to take a longer distance getting all the way through this muscle mass in order to perfuse the entire wall of the muscle. As a result, you have this higher degree of failure of this subendocardial region because of that increase in muscle mass. And so how does hypertensive heart disease look in a clinical sense? Well, you're going to notice there's this entire spectrum of possible complications. And so we've already talked about heart failure as a potential complication. Again, we're looking at a left-sided heart failure. And so there are signs and symptoms associated with that. Recall that hypertension is also going to be a major risk factor for atherosclerosis. The increased pressure that is being delivered to the blood vessels will cause that endothelial cell activation, which can frankly damage endothelial cells, which will cause an increase in the synthesis of cell adhesion molecules, which can then cause platelets to bind to the inner aspect of a blood vessel, thereby producing a thrombus. Sometimes if that thrombus is sufficiently large enough, it can infarct a tissue, or it can detach, and in that case you have an embolism. And for example, if an embolus starts off in the left ventricle, there are the possibilities that it's going to go to cerebral circulation. That's about 10% will cause a stroke. 75% of them are going to go to the lower extremities, which will infarct the lower extremities, and about another 10% go to the various other organs and viscera. Increases in blood pressure is also going to increases the chance of having a focal dilation in a blood vessel, and as a result we can have aneurysmal dilation in a wide variety of arteries throughout the body. Sometimes that can occur in cerebral circulation. If the individual also has atherosclerosis, which is going to be in cerebral vessels, you'll notice that there are going to be cognitive issues as well, and as a result the individual can have atrophy of brain matter, If the individual has really high blood pressure, we can also expect them to have headaches. And if there is, for instance, a pre-existing baryaneurysm, that baryaneurysm has a higher rate of spontaneous rupture. In terms of the retina, when we have hypertensive heart disease along with atherosclerosis, we have these telltale features in the retina when we look at them through the eye, and they're called copper wire arterioles. And the reason why they're called copper wire in appearance, and again, that's a buzzword that I recommend that you guys know, is that as you have atherosclerosis building up in a blood vessel, the amount of blood that is actually traveling through this blood vessel decreases. And so what ends up occurring is that the middle portion of the blood vessel actually tends to take on a copper or even a silver wire look. And so somebody said that looks like a copper wire, and as a result of that, they give it that particular term. High pressure delivery of blood to the kidneys can also cause renal disease. And again, we're going to look at this in our last unit of study, in that you can start to have the deposition of calcium into the nephron, thereby decreasing the amount of blood flow that is going to the kidneys, and an individual can begin to expect to have this chronic renal failure.